What are alternatives to blood transfusions? The blood products have minimum resources with potentially life-threatening side effects. Since blood and its products are considered as drugs, as per IPC, Indian Pharmacopoeia, they are considered as drugs and all drugs should be used judicially. Similarly, same is case about the blood transfusions as well. The benefits and risks with blood transfusions must be carefully weighed in each situation or in every patient. The clear-cut indications of blood transfusions are made clinically along with laboratory support as hemoglobin levels for different types of patients and different types of anemias as well. In pregnancy, keep a minimum hemoglobin levels of at least 10 grams per deciliter. 100 days of iron tablets are mandatory. Every pregnant woman should take 100 days of iron at least after third month onwards. This is very important in order to maintain the iron requirement. If hemoglobin is above 6 grams per deciliter, one can treat the underlying cause of anemia, and in almost 75% of women, they are suffering from anemia. Particularly it's because of physiological blood losses, and that blood losses should be replaced basically at least 10 days of iron in every month females should take. At least the iron loss, physiological blood losses must be maintained and must be replaced. Similarly, we have some iron sucrose. We have in the past we used to give iron sucrose. The dosage is 300 milligram to be dissolved over 2 hours. It has to be given in normal saline. It is to be given. Always iron transfusions should be given in the hospital setting because they carry maximum potential risks as well. Later on, FCM came, and dose of FCM is just 500 to 1000 milligram. It can be given per week. The FCM can be given once a week, 1000 milligram maximum dose, but iron sucrose can be given 900 milligram in 3 divided doses. Presently, now the better iron is ferric carboxymaltose. It should be given in a normal saline in a hospital settings. In addition, for example, we should prefer oral iron number 1. If patient is able to tolerate, if patient has compensatory anemia or decompensated anemia. If the anemia is compensated, that means one can take oral iron. It takes time, although oral iron is safe. Now recently, sarcosomal and liposomal irons are available. They have stomach bypass effect, and they got absorbed directly into the duodenum. They don't get a person doesn't feel irritation in the stomach and constipation, and maximum side effects are less with the newer irons. Iron at least should be given post-operatively, or at least oral iron should be given for months together, 3 to 5 months, depending upon the anemia levels. And mostly oral iron is preferable than even parenteral iron, because parenteral irons can cause more side effects or anaphylaxis reactions. Before starting parenteral iron, we should evaluate the cause of anemia. Either it's iron deficiency anemia, serum iron and serum ferritin should be done properly, and then iron load, then calculation of iron. How much iron is to be given, and when we achieve certain levels of hemoglobin, at least 8 grams, 8 gram onwards we should not give parenteral iron. For that onwards we should give oral iron, whichever salt is tolerable. In the past, iron sorbitol was given, but since the anaphylactic reactions are more with the iron preparations, I will give a brief description about the anaphylactic reactions among 10,000 patients. For example, with iron dextrans, you have an anaphylactic reaction of 9.8 per 10,000. With furomoxetol, you have anaphylactic reaction of 4 4, 4 out of 10,000. For ferric gluconate, you have 1.5 per 10,000. Iron sucrose carries anaphylactic reactions of 1.2 to 10,000. Ferric carboxymaltose carries minimum reactions, although negligible, but 0.8 to out of 10,000. Similarly, iron isomaltidose 0.3 out of 10,000. Always be careful. Whenever you give parenteral iron, it should be given in hospital settings. For example, I will let you know, if you give FCM 1 gram, FCM, 1000 milligram of FCM, it raises hemoglobin up to 3 grams, but over a period of 3 weeks. Only the thing is, blood transfusion raises hemoglobin instantly, almost within 24 hours, from 15 minutes to 24 hours. But ferric carboxymaltose or parenteral iron takes a little time. Although the physiological or psychological benefits with parenteral iron start immediately, and peak effect reaches after 3 weeks. Always prefer oral iron, whichever salt is tolerable. Preferably liposomal iron or sucrosomal iron. You can give twice a day. One more thing, we say we take the food as medicine. Although food has a placebo effect, it will not help in treatment part of the iron deficiency anemia. For that iron deficiency anemia, we need elemental iron, and the proper dosage should be given, and the proper duration is important. At least 3 months we should give iron, 3 to 6 months, and later on maintenance doses should be given. For example, physiological blood losses, at least 10 days in a month should be given. I am sure you have got this message positively and will implement in your practical life. With similar ideas and similar thoughts, I will be coming up with the next video, inshallah. Till next, all the best. Khuda Hafiz.